just before starting this session, I was discussing with some of our residents. So what is the most difficult step in the cataract surgery? So it was coming like the capsulorhexis is one of the difficult steps in the cataract surgery. So I thought we can discuss the capsulorhexis on challenging scenarios, especially like on the white mature cataract. And this presentation was prepared by myself and my colleague Dr. Kiran. So capsulorhexis is perhaps one of the most important steps in the phacoemulsification surgery, and it has got certain advantages that we all know. Like we can do the real bag phacoemulsification, and we can place the lens inside the bag. And suppose if there is PCR, then we can keep the lens in the ciliary surface as well. And the capsulorhexis, after capsulorhexis, the capsule is quite strong in comparison to the like the can opener or the envelope capsulotomy. And why the white mature cataract is challenging? Because we don't have the red reflex, so we have to create a contrast. Entry chamber depth could be shallow, especially in cases of the intumescent cataract, whereas in case of the fibrosed cataract, it could be deep as well. Intralenticular pressure is quite high in cases of the intumescent cataract, and we may miss the cases of the posterior polar cataract. And in long-standing white mature cataract, we can have the intracapsular fibrosis. And in the more ganglion cataract, we don't have the epinuclear support, and long-standing white mature cataract are associated with the zonular weaknesses as well. So this is the way we create the, can we turn off the light on this side? So this is the way like we can create the trypan blue stain. So we have to hold it for the 15 seconds, wash it, and then we can place the viscoelastics, and this case is ready for the capsulorhexis. On one side you can see the more ganglion cataract with the liquefied cortex and the epinucleus, and the nucleus is floating inside the bag. On the other side we can see the intumescent cataract, and we have got this fluid-filled spaces in between the entry capsule and the cortex. And similarly, those kind of spaces also exist in between the posterior capsule and the cortex. So this is one of the cases that I have operated. I started with the capsulorhexis, and I was very happy with the capsulorhexis, but this interlenticular pressure became very high. And then I had extension on one side, and then I had the extension on the other side. So this is a very nice picture of the Argentinian flag: blue, white, and blue. And here also I was very happy. I was just doing the surgery. I stained the entry capsule with the trypan blue and with the viscoelastics, and I thought that everything is going on fine. Till I reached to this stage, and then suddenly I noticed that my capsulorhexis end is going to a very big, and I have tried my best to pull it toward the center, and then I could create the capsulorhexis. I'm quite happy with the outcome, because it was not extended to the periphery, though it is a little bit eccentric. And here I was extra cautious, so I started with the small capsulorhexis after staining the entry capsule with the trypan blue. So this is going on very well. And then I thought I gradually should extend it. And then suddenly at this point of time, I had the extension. And then as a reflex action, I just tried to, you see, so you must not do this kind of movement. Just take the long one scissor, cut it. Because if you do that kind of jerky movement, we are going to extend our rhexis. But the silver lining is that usually this radial cage, it doesn't go posteriorly, and it doesn't become the wrap around here, because we have the thickened mid periphery of the entry capsule that also acts as a kind of a barrier. And another barrier is created by the zonular entry capsular attachment. So because of these two barriers, usually we do not have the extension towards the posterior capsule. So this is one of the, suppose if you have the extension, then what are the options for you? Shall you go ahead with the surgery, or shall you avoid the surgery and convert it to the phacoemulsification, or convert it to the SICS? So in this case, like I was just having the extension, then I thought, okay, I should go ahead with the phacoemulsification surgery. So I had the extension on one side. So again I filled the inner chamber with the viscoelastics. And then I made a leak on the opposite side with the capsulotomy needle. I took the infrared forceps. And then I completed capsulorhexis on the other side. So once I have completed the capsulorhexis, then how can we go ahead with the phacoemulsification? In these kind of cases, we have to be very, very careful. And some people like they advise that you should lower the bottle height, probably that helps, but I never do those kind of things. I just do with the normal phaco settings. But in these cases, I do the phaco chop method for the division of the nucleus, because that gives the less stress on the within the capsular bed. So just divide the nucleus into several pieces, and after division of the nucleus, I do the entry chamber phaco in most of my patients. So we can easily do the entry chamber phaco. And you have to keep on quite good amount of viscoelastics in the entry chamber after removal of every piece. Then probably your endothelium will be also quite okay after the surgery. So once I have removed my nucleus, then I do the bimanual. Especially in these cases, I don't do the bone manual. I do the bimanual irrigation and aspiration, just to remove the remaining cortex and the epinucleus. Because I find that more control with the bimanual ones, especially in these kind of cases. And then here I am just putting the intraocular lens. And you see that my capsulorhexis is not very nice, it is ragged, but even then I am quite happy with the output that the lens is inside the bag. So now I will be sharing some of the tips and tricks to avoid radial tear in white visual cataract. So this is one of the tips, that we can start with the small capsulorhexis and then gradually increase the size of the capsulorhexis in the spiral movement till we reach the optimum diameter that we want. So here I think I have reached the optimum diameter. So I just remove this. Another thing, like in some of my cases where the intralenticular pressure is quite high, I try this method also. I do the initial capsulorhexis, the small one, and then after doing the small capsulorhexis, I finish my phacoemulsification. I do the within the bag phacoemulsification. Then I just fill the entry chamber with the viscoelastics. I make a nip on the entry capsule, and then I do the second capsulorhexis, just to increase the size to the optimal size, that is about 5 millimeters to 5 millimeters. And then after I carry on with the removal of the cortex and placement of the intraocular lens inside the bag. And this is the third way. Like I stain the entry capsule with the pen, I fill it with the viscoelastics, then with the same visco cannula, I just iron the entry capsule. And the main purpose of ironing the entry capsule is so as to create a kind of a flat surface over the entry capsule, and at the same time to redistribute the intralenticular pressure in all the directions. And then I do the small capsulorhexis. And after the small capsulorhexis, I do the partial phacoemulsification. I don't do the complete phacoemulsification. This is one of the like the partial phacoemulsification. And when I do this partial phacoemulsification, then your intralenticular pressure has reduced to very much to the normal. And then I don't have chances of any extension. Then I make a nip and do the second capsulorhexis just of the optimum size and carry out with my usual phacoemulsification and intraocular lens placement. So this is one of the things I found is very useful in my day-to-day practice. And there is another method I call it the ponchoresis. In this I usually use the phaco tip for making the initial hole on the entry capsule. And I do with this longitudinal phaco, not with the torsional one, because with the torsional one you can end up having the large sized opening. And below should be down. And usually we make the punch in the stage 3, because in the stage 3 there is the power and there is the aspiration as well. So whenever I make a hole, at the same time I aspirate the fluid so as to reduce the pressure. And these are my power settings, parameters, and this is the video. Like initially like I made a hole, and then after I catch one of the edge of the this opening, and I can complete my lenses. We can use yard laser also for doing the NJ capsulotomy. So in this procedure, I take the patient to the yard laser room and I do the central capsulotomy and I use as less power as possible. And whenever we are doing the capsulotomy, we have to use the less power. And whenever we do the capsulotomy, we can notice that a gush of fluid has already come out from the lenticular bag into the entry chamber, and that reduces the pressure. If you use a large amount of power, don't use it because it is going to constrict your pupil. We also had one case where we had the constriction of pupil and I got problems in the operation theatre. And we usually do it 10 minutes before taking the patient to the operation theatre. And in the operation theatre, we can extend the recess. So this is the case. Here you can see on one side, like that is the opening that we had created with the yard laser. And then catch one of the edges. And then complete the recess. And this is one of the very complicated cases where we have the intracapsular fibrosis, and these cases are very difficult to do the recess either with the cystotome or with the uterine forceps. So in these cases, this precision pulse capsulotomy is a very, very useful method. And usually you have the intracapsular fibrosis, usually in the cases of the trauma or the hypertension and non-standing cataracts. So here we have made the initial cut with the capsulotomy, and you see that there are fibrous adhesions are there. So I literally had to pull it, and I am just trying to magnify the view. And here you can see that there are fibrous bands are there. This would have been very, very difficult with the cystotome or with the uterine forceps. So just to conclude, right mature cataract is not an uncommon entity. In our day-to-day practice, we see a lot of cases, and we don't need to do SICs in all these cases. We can do a very nice recess. That is one of the very difficult white mature cataract. But with the help of trypan glue and with the proper instruments like the cystotome, uterine forceps, and non-venous and with proper selection of techniques, we can do perfect CCC in almost all our cases of the white mature cataract. So thank you very much.